Hello, today I'm going to discuss adenoid cystic carcinoma. Adenoid cystic carcinoma is a malignant tumor of salivary glands. It's more seen in minor salivary glands than in major salivary glands. And among minor salivary glands, it is more commonly seen in palate. Among major salivary glands, submandibular glands are most commonly affected. The tumor has a tendency for perineural spread. Now, this picture is showing a lesion on lateral side of the palate. The lesion is slow growing, and according to the history, it is associated with pain, and the pain was seen even before the growth of the swelling. There is constant dull pain, there is a smooth surface, and it has caused mobility of surrounding teeth. So, this tumor is categorized as low grade tumor. This picture showing a swelling which is ulcerated, is not capsulated, and the patient had mild symptoms, there was mild pain. The tumor can have abrupt growth and it can cause distant metastasis and can show multiple recurrences and aggression. So both of these tumors can cause invasion in perineural areas. There can be metastasis to other areas. There is high recurrence rate and aggression depends on the histopathological grade. Grade 1 has got good prognosis, whereas grade 3, which is dominated by solid pattern, has got worse prognosis. Regarding the history, it was first described by Billroth in 1856. It was called as cylindroma. The word cylindroma because the individual islands can have pseudospaces which are cylindrical in shape and there is cribriform appearance. So, please remember there are three C's: cylindroma, cribriform, and cylindrical. The cribriform appearance is also called as Swiss cheese appearance. The term cylindroma is not used now because it doesn't indicate malignant nature of tumor. Clinically, they are located more in minor salivary glands and in palate. Half of the adenoid cystic carcinomas are seen. Among major salivary glands, submandibular glands are more affected than carotid and sublingual glands. Here we have to remember that sublingual glands are very rarely affected by adenoid cystic carcinoma. It is more commonly seen in 5th and 6th decade of life, although the age can occur in any age. It can occur from 2nd to 7th or 8th decade of life. And like other salivary gland tumors, most of the other salivary glands occur in females, and so adenoid cystic also seen predominantly in females. The etiopathogenesis is that there is unicellular theory of origin. It is again followed for adenoid cystic carcinomas, meaning thereby that intercalated ductal reserve cell is considered as the cell of origin. This cell will give rise to epithelial and myoepithelial cells. Then there can be neoplasia of these cells and of the tumor. Histopathologically, ductal cells and myoepithelial cells are seen. Ductal cells are cuboidal cells with hyperchromatic nuclei, whereas myoepithelial cells are angulated spindle cells which have got scanty nucleus. Three histopathological patterns we have to remember. These are cribriform pattern, tubular pattern, and solid pattern. The cribriform pattern is made of islands of basaloid epithelial cells, and each island has got enough cylindrical pseudospaces which are largely empty, but they can contain mucoid or helionized appearance. Oh, sorry, mucoid or hyalinized material. So, Based on the shape, it is called as cribriform variety of adenoid cystic carcinoma. Each of the island is surrounded by hyalinized eosinophil material. Here in this picture, we are seeing large number of tubules, and each tubule has a central lumen. The lumen is surrounded by cuboidal cells and myoepithelial cells. So, tubular pattern of adenoid cystic carcinoma has got hyalinized stroma, and the lumen lined by cuboidal cells, outer layers of modified myoepithelial cells. Third variety of adenoid cystic carcinoma is solid variety. Solid variety contains large islands and sheets of tumor cells. The cribriform appearance is not seen. There is increased mitotic activity and focal necrotic area seen. All three patterns coexist in the same tumor, and usually one pattern predominates. Based on the pattern, adenoid cystic carcinomas are graded as grade 1, grade 2, and grade 3. The grade 1 can be cribriform, tubular. Grade 2, if the component solid variety is less than 30%, then it is grade 2. But if solid component, then one third total tumor pattern categorized as grade 3 cystic carcinoma. Have to remember that grade 3 has worse prognosis. Probably there is focal necrosis, pathology of cells, raised mitotic activity, tendency for more pollution. Regarding the differential diagnosis, most important differential diagnosis, polymorphous low-grade adenocarcinoma, because polymorphous low-grade adenocarcinoma again has a tendency for perineural spread, but we differentiate it by using c-KIT immunohistochemical compound. So a c-KIT not expressed in PLGA. Polymorphous adenocarcinoma doesn't have angular cells in. The second important differential diagnosis, basal cell adenoma, was again basal cell adenoma, islands of cells which are basal cells. But in basal cell adenoma, no perineural invasion. Secondly, carotid is most common, benign tumor. Third important differential diagnosis, basal cell adenoma. But in basal cell adenoma, no cribriform pattern. Secondly, peripheral palisaded islands. Regarding the treatment of adenoid cystic carcinoma, radical surgical resection, radiotherapy, cause adenoid cystic feed structures, prognosis, 5-year survival rate is 75%, while 15-year survival rate is 10%. And number two, prognosis dependent on the grade of the tumor, cribriform variety has good prognosis, solid type carcinoma has